particularly interested in whether we can use observational data to try and inform clinical practice, and that's my main focus, although that's filtered through lots of different studies. So as Swap said, I've got this kind of really incredibly fortunate dual role of having a clinical service and also being an academic, and I work with this incredible group of people at LSHTM. So we're all very familiar with this idea of a hierarchy of evidence with good quality randomised trials and preferably meta-analysed to provide the strongest form of clinical data. And clearly that's incredibly valuable, and randomisation provides analysis free of sources of bias and confounding, which is certainly the strongest form of evidence when done well. But there are many situations where RCTs can't be done, or it's not feasible, or we could perhaps optimise our practice using observational data. And as Swap mentioned, we have this incredible new platform in the UK, the Open Safely platform, which was set up through COVID and has been a huge resource and a joy to work on. And this is just a kind of taster of the type of data that we have. So it's all comes from one set of GP service providers who look after the data for one group of primary care providers, and that's about 45% of the English population, so about 24 million people. And that's been linked to a whole host of different data sources around COVID, hospitalisation, mortality, intensive care, and then increasingly to kind of more bespoke cohorts and the UK renal registry. So huge opportunity to do high quality observational research, but also bearing in mind the limitations of that as an approach. And here are the problems. In any observational study, we always think about the play of chance, random error, but in these extremely large data sources, random error really is not problematic because we have such large data quantities, but we're still stuck with bias and confounding, which can be really problematic. And my little confounding picture there is to remind me of the example of early on in the COVID pandemic, when there appeared to be very strong evidence that baldness was a risk factor for COVID mortality. And that was, and there's several, robust papers came out on this, but clearly highlighting the combined effects of male sex and age. So in the UK, we are trying to make better use of routine analysis for driving healthcare. And hopefully you'll be aware that there's a healthcare body in the UK called the National Institute of Clinical and Care Excellence, or NICE, which sets national guidelines and reviews medications as to whether they are cost effective to be introduced into routine care. And they are trying to use real world data to inform clinical guidance. So how can we support them in that? Do we need to better train clinical academics? How can we optimise study design? And in particular, how can we give people the skills to better interpret data? So I'm going to talk about two examples of my work, and in an ideal world we'd have a discussion about what you think about whether this strength of evidence is strong enough to try and inform practice. But do feel free to chip in. This is very informal, and I hope you realise I'm very approachable. So we're going to start off thinking about blood pressure treatment algorithms. And again, this is very UK specific, but it does relate to international guidelines, although they aren't so prescriptive. So in the UK, we have a formal algorithm for primary care providers to decide who should get what drug at the initiation of antihypertensive treatment. And what it boils down to is if you're under 55, not a diabetic or black, you should be commenced on an ACE inhibitor or an angiotensin receptor blocker. Whereas if you're black or all diabetics should get ACE and ARBs first line regardless of age, black people should get CCBs regardless of age. And that's based on some quite historic evidence that you may now feel is really quite outdated. And again, this is you may not be so aware of this in Canada. I think this is very much a British concept, and it's very much embedded in the British literature. And and in British clinical training when I was a medical student, that there were fundamental differences in the phenotypes of hypertensives between people of different ethnicities. And there were lots of what now, even 20 years on, look quite offensive stereotypes about why people would have very different phenotypes of hypertension, even in a similar high-income country environment. And this was one of the main papers that drove this concept. So it's an NEGM paper, and it's not. I mean, that was when I was in clinical training. It's not in deepest history, and yet not at all the quality of evidence that we would accept to drive practice today. So in this paper, they very crudely divided people up into younger and older, black and white, and they gave them different types of antihypertensives and looked to see where there were substantial falls in blood pressure, and whether there were differences between the groups. And as I mentioned, this is one of the main papers that underlies the difference in treatment patterns. But these days we've come to view ethnicity much more as a social construct, where differences in skin colour are not a great way of dividing up clinical treatments, and multiple factors may play a part. And in particular in the UK, we have a very large proportion of the population who are of mixed ethnicities, and it's not at all clear how best to treat people from the mixed ethnic groups. So I was very keen to try and see how these guidelines played out in clinical practice, and so we conducted this study, which I'm going to walk you through. And these are the clinical questions that we set out to address, based very much on that algorithm that I showed you that still remains in our main clinical practice at present. So among non-diabetic, non-black people, do we see a difference in the amount of change in blood pressure between those starting calcium channel blockers and those starting ARBs above and below 55 years? So is the difference in blood pressure different in different age groups? And then similarly, is the difference in blood pressure different between people of black and non-black ethnicity? Just to make a very pedantic point, if you think back to the NEGM paper, they had this concept of black and white, but the algorithm as it currently is black and non-black. And so we grouped all people who didn't self-describe black ethnicity as non-black to reflect clinical practice, and that's slightly different from the original research base, but it is what is in the current algorithm. So this is I'll walk you through our cohort study. So this is our timeline of an individual or a study going forward. So we identified people after January 2007 with adequate GP records who'd been in the GP practice for long enough to have their comorbidities recorded and were over 18. And within that study population, we identified non-diabetics who initiated an ACE inhibitor, an ARB, or a calcium channel blocker. And we did also look at thiazides, but I'm not going to talk about that today. And then we followed them up until either the end of the study in 2017 or the end of when they left the GP practice, or the GP practice stopped giving data, or when the individuals died. And we restricted the study population to everyone who'd had a measurement of blood pressure in the year before the study began, or before they entered the study rather, and that it was in the hypertensive range, to try and minimise the number of people who were commencing for, let's say, heart failure or kidney disease. And we linked to other sources of administrative data to try and minimise missing ethnicity data, because it's captured differently in different data sources, and we wanted to have complete data on ethnicity. And then our main outcome was the change in blood pressure between baseline and various different time points, and then to try and identify that we were capturing things that were causally related with the drugs that people were being initiated on, as opposed to the factors for why they got the drugs. And we chose to look at positive controls. So those are things that we should be different between the different drug classes, and if we are finding a causal effect, we would expect those to be different between the different groups. And then a negative control, and that's herpes zoster, which is often used to see if there's a difference in frailty between the groups, because subtle differences in health can be difficult to capture in routine data, whereas something like herpes zoster, which is more common in frail patients, can show that effect, whether there's still residual confounding by basic health. So we went through those stages to develop a cohort, and then down here at the bottom we have not huge numbers, but reasonable numbers, around 87,000 new ACE/ARB users and 67,000 new CCB users. So obviously much higher than you'd ever get in a clinical study, and we were trying to identify a clean, well-described population. And in our analysis, of course, there still remains substantial sources of confounding of things that may be associated with why the GP chose to give that drug, potentially, rather than following the treatment guidelines. So we tried to adjust for many of those. Obviously, heart failure, kidney disease are key ones that we would be thinking of. So this is our analysis. Oh, sorry. We compared the fall in blood pressure between propensity score matched cohorts of the calcium channel blockers and the new ACE/ARB users, and then we modelled the change in blood pressure at the 3 different time points we were interested in. And as I mentioned, we using a Cox proportional hazard model, we looked at the control, the positive and the negative controls within each of the propensity score matched groups. We also, rather than looking above and below 55, we divided into smaller age group categories to try and see if there was any kind of change over time, or whether we could pick up a pattern of the difference in change in blood pressure with different ages. And then we also looked at an as treated analysis effectively, where we followed patients up until they were switched to a different drug, or discontinued their drug, or added in another drug. So to focus specifically on the effect of that one main drug that they were initiated on. So these are our key findings. So this is the analysis in relation to age, and here we're predominantly comparing the those of the same age. So if we look here at the blue line, that's the fall in blood pressure from initiation for those commencing ACE/ARB users below the age of 55. And if we compare that to CCB users below the age of 55, that's the pink line here, and we can see that they're very similar. But what we do see is that people, younger people aged less than 55, had a slightly greater fall in blood pressure than those aged over 55 at the time of drug initiation. But again, the fall between CCB users and ACE/ARB users was very similar, comparing the 2 groups over 55. So not a substantial difference in the change in blood pressure between the age groups. And this is the analysis for ethnicity. So if we compare people who are Black initiating different groups, first of all, so here we're comparing the purple line. So that's people initiating ACE and ARB who are Black, with the pink line, that's people initiating CCB who are Black. And here we do see a slightly greater fall. You can see there's a discrepancy between the lines. We do see a slightly greater fall among CCB users, but the confidence intervals do overlap. So it's not a substantially different or greater fall among CCB users who are Black. So this does support the guideline to some extent, in that we do see a slightly greater fall, but it's not very substantial. And when we look at these small age groups, so this is now analysing the difference in blood pressure by people aged less than 54 and then in 5-year age bands up to over 75. And what we're seeing plotted here is the difference in blood pressure in millimetres of mercury. So below the 0 line, calcium channel blockers have a larger fall in blood pressure. And this purple line here is the 12-week fall. So that's the greatest fall in blood pressure. And as you can see, calcium channel blockers clearly lead to a greater fall in blood pressure than ARB in younger people, and also in people over the age of 75. But in between, they cross, the confidence intervals cross the 0 line. So there's no substantial difference in blood pressure between people initiating the 2 different drugs. And just to remind you that this is the cutoff for the NICE guidance. So everyone above this line here, older than this age group, should be getting CCB as their first line treatment. And so you might, if you felt there was a specific indication for an ARB, in addition to blood pressure alone, such as proteinuria, these people would preferentially be missing out on potential benefits of RAS blockade. So these are the results for our control analysis. So here is a forest plot, here's 1, so no difference between the drugs. And here is ankle swelling, which obviously we would anticipate to be worse with calcium channel blockade. And we can see there's nearly a doubling of the risk of having ankle swelling recorded in your GP record after initiating a calcium channel blockade compared to an ARB. So very much supporting that there is a drug effect playing a part in our results. Angioedema, the point estimate is much worse, as you would anticipate for ARB, but it was a rare event, so the confidence intervals cross 1. And the gout is only here in relation to the thiazide analysis, where we did show a substantially greater risk of gout for people initiating thiazide. So that was our main results of our study. Of course, there are clear limitations to this type of analysis, and we tried to be very open and honest about what they were. So even though we tried our best to identify people who were initiating ARB for another reason, routine data is never perfect, and particularly in relation to heart failure. Even in this large study, once we restricted to certain subgroups, there were relatively small numbers. And of course, there's always measurement error for blood pressure as a classic epidemiological problem, although I'm not sure that it would be different between ARB and calcium channel blocker. And so you wouldn't expect a differential error. But the strengths, very large population, people being treated in routine care. We did only include people with baseline evidence of hypertension, and we tried very hard to identify sources of bias to describe them. And finally, this reflects what's going on in the UK over the last 15 years. So reflecting our current ethnically diverse population, and therefore very different from the kind of previous clinical studies that have led to this guidance. So overall, we found no difference in blood pressure reduction between the drug classes comparing younger and older people. And although there was the point estimates were below the null, the confidence intervals overlapped between black and non-black. So it's 20 past. So do you want to have a chat about this study first and then move on to the second one, or should we just go straight through? What's your preference?
I think you might as well go. We can chat at the end. Okay,
great. So hopefully you've got some thoughts about, the errors in that study and whether or not you would feel that we should be changing our UK-based algorithm. So stick that in your brain. So I'm going to move on to another study, another aspect of care, and that's I'm obviously particularly interested in RAS blockade and acute kidney injury, and that's where a lot of my early work was. So we know that there is a small increased risk of developing AKI in the general population who are prescribed ACE and ARBs, much smaller than you would perhaps imagine if you're admitting elderly patients, and that's largely to do with confounding by indication. This is all my opinion, but we quantified it in that paper listed there, and we found there was only a 12% increase in rate of AKI among people who were taking ACE/ARB compared to people who'd been commenced on calcium channel blockade. There's an ongoing debate, perhaps less fierce than it was a few years ago, which is good, about the value of sick day rules and about what we should do to stop ASARB during periods of acute illness. But current UK guidance still suggests that ASARBs should be stopped when patients are acutely unwell, and obviously if they are hypotensive or hyperkalemic, that's definitely going to happen anyway. But there is no clear guidance on when they should be restarted. So if you look through our NICE AKI guidance or KDIGO, it's not clear that how and when we should decide about restarting the drugs. The period after developing AKI is one where there's loss of acute illness, patients are at very high risk of morbidity and mortality. And in particular, as you can see by this paper by Go et al., there's a particularly high rate of readmission with heart failure. And that's problematic. It's also problematic epidemiologically because is it that patients have developed AKI and they go on to develop heart failure? Is it that these patients all have advanced chronic kidney disease and they're in a very uncertain fluid balance and they tip over into heart failure more easily? Or is it that they've had their drugs stopped and they end up coming back into hospital quite quickly with fluid overload because their diuretics and RAS blockade and so on were stopped during their previous admission? So as clinicians, we're faced with the problem of people coming in with AKI and surviving, and then what do we do with their drugs? At what stage should we restart them? So we were keen to try and look at this. There were some previous papers on this. There was hopefully you'll be vaguely familiar with these. So the BRA paper covered a large group of people who were admitted with AKI, and they were a mixture of ASARB users and non-users, and they looked at a range of outcomes, but in particular they had this hospitalisation for a renal cause, which encompassed patients who had heart failure. So their main finding was that people who took ASARB after discharge had a lower mortality compared to those who didn't remain on the drugs, but they were at higher risk of this adverse renal outcome. And I think I wrote an FJC summary when we did that in FJC, which is listed there if anyone wants to have a look at my more detailed thoughts about the paper. And then there's the Hugh paper, and that was patients not taking RAS inhibitors admitted with AKI, and then went on to look at those people who were admitted with ASARB after discharge and didn't identify an increased risk in those people, solving the clinical problem of if you've had previous AKI, it's okay to start ACE inhibitors subsequently, but of course that's not the clinical problem that we're faced with most commonly, which is recurrent people who are being recurrently admitted, multiple comorbidities, already taking multiple drugs. So within that context, we went on to undertake this study, which is comparing people who've stopped or restarted renin-angiotensin-assisted blockers and looking at various different adverse outcomes. And we conducted this both in English data and also in Swedish data. So as I mentioned, this is the clinical scenario we're trying to address. A person prescribed an ACE or an ARB is admitted to hospital with AKI, and they survive hospitalisation and they're discharged. And so their primary care provider is then faced with the decision about should they stop or restart the drug and when should they do it. Clearly, they're worried about further AKI if they restart the drug, but again, possible increased risk of heart failure. And we went on to look at these various different outcomes: heart failure, AKI, stroke and death. So the English cohort was conducted in the Clinical Practice Research Data Link. I should have said that's the same data source as we used for the previous blood pressure paper. And all of that was again linked to HES, which is administrative data about hospitalisation to pick up when people were admitted and their subsequent outcomes and so on. And the Swedish data was conducted in the SCREAM cohort, that's Juan Jesus Carrero's large cohort of patients based around Copenhagen of everybody who'd had a creatinine measured, and that was linked to secondary care and prescribing data. So our primary exposure was, I'll show you this in more detail in a minute, so it's quite complicated, is patients who didn't get an ACE and ARB re-prescribed within 30 days of being discharged. So obviously we're comparing those to people who did have ACE and ARB re-prescribed. And our primary outcome was heart failure hospitalisation. So there are many sources of bias in trying to conduct a study like this. And here I'm just highlighting a couple of the main sources of bias. So I'm not sure if it's the same in Canadian practice, but in the UK, if someone's being discharged from hospital, we will give them 2 weeks of the medication that we wish them to continue with on discharge, so that they don't have to worry about going back to their GP. They don't have to worry about any changes to their previous tablets. They've got a clear pack of this is what we want you to take for 2 weeks. But that data isn't captured in any routine data sources. And so we don't know whether patients were given ACE inhibitors or ARBs by their healthcare provider in hospital when they leave hospital. So we can only detect patients being given an ACE and ARB when they go back to their GP and they are collecting them or being prescribed them by their GP, and that's when we detect that in the primary care record. But that introduces this problem of immortal time bias. So if you're very sick and you go straight back into hospital again, or you die very quickly after being discharged rather, you won't have the opportunity to go to your GP and be re-prescribed the drug. And so there's a period of time after being left from hospital where really we don't know whether you've got the drug. And if we were simply to compare, if we were to include all that period of time, we would be including time from people who were never really able to be included in the study. And so this is the study design we used to try and minimise this. So our study ran between January 2010 and the end of 2016. And we identified people who were being prescribed ACE and ARB on an ongoing basis by their GP. And then people within that group of people, we restricted to people who were then admitted to hospital with AKI. So we've now got a group of ACE/ARB users who've had an AKI. We excluded people who had had end-stage renal disease, dialysis, or previous AKI in their past medical history. And then we began to follow them up after discharge, and we didn't include any of that 30-day time period. So we only included people who were alive and starting follow-up at 30 days after their discharge. And during that 30-day period, we identified those who either remained off or restarted ACE/ARBs. And we went on to look at the outcomes I've mentioned previously, and also censored them an outcome. If they had an outcome, they were censored in that analysis, death, or if they left CPRD, or at 2 years after discharge from AKI. And that's because if you continue to follow them up over longer term, it's much harder to draw associations between a one-off exposure and long-term outcomes. So again, we developed the cohort within the English data. And again, we ended up with for a routine data analysis, not huge numbers because we're restricting to these AKI group. So about 7,000 odd people who we were able to look at for each particular outcome. And the difference is because people were censored if they went into hospital with any of the outcomes. And we replicated that very directly within the Swedish cohort, making just a couple of tweaks for differences in data with Sweden. So, for example, ethnicity is not recorded by law in Sweden. So this left us with the baseline populations. And I think that if you look down the columns, these will very much reflect the kind of people that you see in routine practice. So mean age of 77, about actually about nearly 50-50 men and women, and then a very high proportion of different comorbidities, so about 50% diabetic, large proportion of patients with heart failure, and a lot of concurrent medications. And actually, they very well matched between the continuers and the stoppers, surprisingly, and that's, we hope, it's that because there is no clear direction as to whether or not to continue or to stop the medication, it adds an element of randomization. Different GPs will work in different ways and have different clinical practices. So it's not a clearly directed choice. This degree of randomization adds to the value of an observational analysis. In the English cohort, we were also able to identify those who had dialysis during their admission, so relatively small proportions, obviously greater in those who remained off treatment, but that data wasn't captured in Sweden. So I mentioned this 30-day period, and this was a slightly iterative process of us looking at the data to decide how long we were going to allow for the decision to be made about whether we classified people as restarting the drug or not. And so we got all the data and looked at it in this way. And this is the proportion of people who are re-prescribed ACE and ARBs after discharge following AKI here in England and here in Sweden. And here in 30 days, you can see that 42% of the cohort are re-prescribed ACE and ARB at 30 days, and even at 90 days it's only 55%, so about half, 45% of people never go on to be prescribed ACE ARB after AKI. And if you take all of the people who are ever prescribed ACE ARB at 30 days, so it's 75% who will ever go on to be prescribed it are re-prescribed it at 30 days. In Sweden, perhaps a subtly different picture in that there's a kind of much more linear, incremental process of people going on to be re-prescribed the drug. But here it's about 67% are re-prescribed the drug at 30 days. So we took this as our main analysis because it captures the majority of people, but it minimises the immortal time during which time people will be dying or going back into hospital. So it's literally a balance between capturing the most people or losing the most time. And then we went on to look at 60 and 90 days as well as sensitivity analysis to see if those changed our findings. So this was our main result. So again, a forest plot with the line of null in the middle here for 1, and that would be no difference between those stopped or re-prescribed ACE ARB. So here in England, you can see that all of the lines crossed the null. So there was the effect estimate was to the side of a greater risk of people who stop, but the confidence intervals cross 1. AKI, a slightly lower risk in people who stopped ACE ARB, but the confidence intervals crossed. And here in England, we saw a greater increase in death. So 27% increased risk of death for people who stopped ACE ARB after AKI. And we'll probably come back to that in a minute, but it's always the question of, is that residual confounding that the people who weren't re-prescribed the drugs were simply sicker and that's why they never got them? Or was that a causal effect? Whereas in Sweden, again, null effects for heart failure and AKI, but also a null effect for death. And interestingly, the Swedish group have gone on to reanalyse this data in a much larger data set in a paper that came out fairly recently, and they actually now show the same effect as us, as the greater effect of death in a larger cohort, analysed slightly differently. So I mentioned we conducted a lot of sensitivity analyses to try and see how robust our data was. So there's a tool called the Electronic Frailty Index. It's actually a clinical tool in the UK. It's embedded into GP databases to pick up frailty levels among their patients, but you can also use it as a tool to try and use multiple data sources to try and get a better picture of frailty in your patients. So we also included that in our analysis. We also define the exposure, comparing the exposed and unexposed at 60 days post-discharge. We ensured that people were repeat users of ACE/ARB before their AKI admission. We strengthened the certainty that the patients were having the outcome by only using the first diagnostic position in the hospital coding data. We excluded people who'd had dialysis. We stratified the time intervals, and we also excluded everyone who'd been readmitted within 30 days after the baseline AKI hospitalisation. So this is a problematic study, lots of sources of bias, but trying to minimise those through lots of different approaches. This is all of the sensitivity analyses for all of the outcomes in England, and essentially they're very consistent with what we saw in the main analysis. So no major differences. This was the the Swedish data I mentioned, where they've gone on to look at it in a larger cohort. And this is recurrent AKI. And as you can see, there's no difference in recurrent AKI between people who continue or stop the RAS inhibition after AKI. There is a difference in hyperkalemia, which is really nice because it points to a causal effect. Obviously, you would anticipate that the people who restart the drugs have a higher potassium, and so the separation between the lines in the continuers is encouraging. But here, when they look at this composite of mortality and major adverse cardiac events, they find that's higher in the people who didn't restart ACE inhibitors or RAS blockades in general after the AKI. So now much more similar to what we showed in the English data. So overall, there's 2 cohort studies, and 3 if you include the one that I mentioned that was under review but is now published, show that there's a lower risk of death among people who restart ACE/ARB after hospitalisation with AKI, and none of the studies have shown an association with recurrent AKI. So there's the possible apparent protective effect on mortality from residual confounding by frailty or end-of-life care among people who didn't restart the drugs. And so it's very unlikely that anyone's going to conduct a randomised trial to randomise people to stopping or restarting RAS blockade after AKI. And so perhaps the cohort studies that I've discussed are the strongest evidence we're going to get. And so, you know, if you were writing the next iteration of the KDIGO guidelines, would you feel that the observational data was strong enough to recommend restarting the drugs? So where are we? 20 minutes to go. Perfect. So I'll stop there. Thanks very much for your silence. I hope it was of some interest, and I will be very interested to hear your thoughts.
Thank you. That was a wonderful overview. If people have questions, please raise your hand or unmute yourself and ask questions. But I'll go first with the first paper on hypertension, right? Because I'm a hypertension geek. You showed the difference in blood pressure, and by 52 weeks, it sort of seems to be not much of a difference, perhaps. Is there going to be any attempt to look at outcomes in the long run, like clinical outcomes? Is that something you're looking at, or do you think it becomes even more messy with time?
Yeah, so that was a fascinating finding, and I'm still thinking about it, and I've actually talking to a group in Australia who are interested in doing some work using the run-in period from clinical trials to kind of try and look at this effect. I mean, obviously you would expect tachyphylaxis, that the effect of the drugs does wear off over time, but what you're clearly showing is that if you look at this in routine data, you get a very large fall in blood pressure, perhaps larger than you might see in a clinical trial, that then wears off over time. And whether this is a true effect or whether it's all due to people becoming less concordant with their medication, I genuinely don't know. It's worrying.
Exactly, it is worrying. Yeah, and I'm sure non-concordance, non-adherence is also a part of this issue. Maybe Mark first and then Yolanda.
Thanks, Bob. Thanks, Laurie. I really enjoyed that. I struggle with some of these issues because there's so many decisions to make, and you spend like a year thinking about how to design it to minimize these sources of bias. You do 1 million sensitivity analysis, and then of course it goes out to review, and 7 people come back telling you how you should have done it, and you know. So, but one of the things when you had like multiple outcomes in that ACE-ARB study. So my first question is, because obviously in the Cox model, you're looking at the long-term risk, right, from time 0. So like, are each of those outcomes mutually exclusive? Like, is it time to first? In other words, like if you have an acute kidney injury at year 2, like could you actually have had the stroke at year 1? Like how did you deal with those events along the way? And then the second issue is with that death signal. Like, is there a need to look at the other outcomes, not with that sensor, but rather as competing risk?
So really good questions, and you have to forgive me if I'm a little bit rusty because my brain's entirely full of COVID, both clinically and personally. So in relation to your first question, so people were only sensitive to that individual outcome. So if you had a stroke, then you couldn't go on to have another stroke, but you could go on to have AKI or any of the other outcomes, and similarly. So yeah, trying to capture the clinical course of the multiplicity of clinical outcomes that very sick group of patients have, but not being influenced by multiple outcomes of the same event as you often see within individuals. In relation to competing risk of death, I mean, it's always very problematic, and I think you're probably right that we haven't captured that really well in that analysis, and we didn't do any specific formal competing risk of death analysis there. I do genuinely think that we don't do very well at competing risk of death, either in interpreting it or in working out how best to analyse it. And often, the most useful clinical information is simply by comparing the graphs side by side and seeing, what's going on. And I mean, in that population, we know that there is a very high risk of death, and so really we're looking at the survivors at each time point because people are obviously being sentenced to death. So that can slightly change your clinical reasoning. If this population is largely dying and we're seeing the outcomes among the survivors, how well do we implement that clinical decision in patients who we don't yet know if they're going to die? And I don't know the answer. It's a problem about implementation of clinical of non-randomized evidence.
Yeah, for sure. But I guess when you had at least in the English cohort, there was a clear differential risk based on the exposure, which just makes you think about what would the cumulative incidence have been of your other outcomes, like acute kidney injury.
Yeah, more to do.
Thanks.
So Yolanda?
Yeah. Can you tell us a little bit more about the database? It's primary care. You said it was 45% of the primary care. So like, where does this come from? Is this a event? Like, why 45%? Can you tell me a bit more about that?
Yeah, so I've confused you by giving different sources of data in different bits of the study. So Open Safely is 45% of England, and that's because it includes all data, but it's in fact built on top of the database of one of the primary care providers. So in the UK, we have 3 main people who, 3 organisations who provide primary care data to GPs, and so they will provide the infrastructure that the GP uses to manage outpatient clinical care, and then that's all captured in a particular database, and the providers then use that data for research. So TPP give it to Open Safely, EMIS, who's about 50% of England, they give it to QRisk, which you might have heard of, which is a very influential research organisation in Britain. And then EMIS and Vision, which is the third provider, give it to CPRD, which is the kind of British government-owned data source. And that's what's used in the work I've discussed about blood pressure and about AKI. So they are just simply providers of GP software who capture all of the GP data and provide it for research purposes.
And are there any systematic differences between sort of, which GPs or which areas or which regions or which socioeconomic status, is using one versus the other? Is that a potential source of bias?
Yeah, so really good question. We have, for example, in TPP, we have recently compared all of those kind of demographic variables to the census data to look for the differences, and effectively the GPs are capturing a kind of representative subset of the population. All of the ethnicity, socio-demographic factors and age distributions are all similar to the national data, but there is big regional differences, and that's just because, if some GP in your area, leading GP, has started using one particular data source, then everyone else joins in and you get a hub forming. So there are big differences across the UK. So the big difference with Open Safely is it's predominantly based outside of London, and particularly in the north of England. In the data I've shown you, it's fairly representative. It's a lot more representation of London with its ethnic diversity. I don't think it really presents a big problem for most analysis, because most GPs are following the national guidance regardless of where they are in the country. It has presented us with quite a major problem in COVID because at different periods there are different prevalences in different parts of the country, and so analysing the data as a whole can be problematic.
Thank you.
Ted, and then Peter.
Hi, Dr. Tomlinson. Thank you very much. Great talk. Just had a question about the definition of AKI in terms of how hospitalizations with AKI were defined. And is there a capacity to kind of get a better sense of the severity of AKI? Because I think, my sense of that is a very different population of patients who have mild AKI. You might be doing them a real disservice by not restarting them down the road. But was it possible to look at that in terms of severity?
No, I should have said all that. Sorry, that's such an obvious question. Sorry. So the data we've used is the coding that's used for hospitalisation data, and we have looked at this in a great deal of detail previously. And what we know is that if you have the code, you almost certainly have had AKI. So it's got very high positive predictive value. There's an awful lot of people in whom it's not coded and it's not detected. But the people in whom it is coded tend to have more severe AKI. So it proportionately captures a greater proportion of people with grade 3. We don't have hospital biochemistry data, so we can't look at biochemical AKI in the UK. So overall, our results will be being driven by people with AKI1 because they are they're the vast majority of people with AKI. But we are capturing a greater number of people with 2 and 3 compared to the overall spread of AKI, the whole population of AKI. Whether our results differ by AKI grade or severity, really good question. I would anticipate that they would be exactly as you've described, but I don't know because we don't have that data.
Any signal on there's a small number of patients, but with dialysis requiring AKI?
Well, I think because it's such a small population, excluding them didn't make any difference to the result. But I don't think that's because I don't think that we can interpret that as cause. I think it's just that we're only a small number of people.
Thank you.
Thank you. And Peter, I think.
Yeah, hi. Sitting in a car.
Oh, it was an aeroplane. I'm glad to hear it's a car.
So I'm interested in the clinical decision about restarting ACE/ARB after an episode of AKI. And I've always thought it really unfair that people get discharged to see the GP that 20 or 30% of our patients don't have. But the discharge summary still says see primary care physician in 2 or 3 weeks to reassess or whatever. And that GP probably doesn't have the tools to decide whether it's the right decision to restart or not. So I think it behooves us to provide direction / restart them at day 3 of hospital admission if things have been improving, which almost never happens. But some of that, for me, the decision is based on degree of frailty. Are they the sort of person who's going to go home and not eat and get volume depleted again and get another AKI? And I guess maybe your data set captures some measures of frailty, and I'd be interested in whether they impact on outcomes. But the other thing perhaps I missed it is, what's the indication for the ACE/ARB? Because if it's just for hypertension, that's to me not a pressing indication. But if it's for low ejection fraction heart failure or heavily proteinuric CKD, then you might have more incentive to restart it. And maybe I missed whether you controlled for those things.
Yeah, so really great question, and slightly disappointed to hear that you haven't got this sorted in Canada, because what you say is exactly the same as what we do in England. It's interesting. Having been working so intensively on COVID for 2 years, I think it's changed a lot of my thoughts about what, it's hard to look back on your results and think, what would I have done differently now? So in the analysis that I've described, we adjusted for those things, but clearly stratification by those things would have been much more informative. And it would be really nice to be able to tell you, among the patients who had coded heart failure at the beginning, this is what we see. Among the patients who were known to have proteinuric renal disease at the beginning, this is what we see. So I can't tell you the answer. I wish I could. What the result we're giving you is, having taken account of all of those different comorbidities, this is what we see. But I agree with you that fundamental indication is so critical to that's actually much more useful. In relation to frailty, adjusting for observed frailty didn't make any difference. However, I think that you're absolutely right in that a substantial proportion of people who were very frail never got restarted on the drugs, and that was why they went on to die rapidly. And so that's why we see this strong signal for death, or part of the reason why we see the strong signal for death. I have slightly changed my thinking on this. I used to say it was all residual confounding, but I think that the consistency of results across multiple different studies. So I mentioned the second Swedish study, which shows the separation for age. And several other analyses. I don't know if you've ever discussed the paper by Edward Fu and Jason, where he looked at, can't remember what he looked at now, but it was to do with RAS blockade and CK initiation of dialysis and mortality. And he again showed us this signal for death. And I've come to think it is to some extent causal. And so I'm much more proactive about starting the drugs in patients, even if I think they're at quite high risk, than I used to be. And that's just driven by this consistency of the signal across multiple studies, where they've really tried hard to take account of frailty and reasons why people wouldn't be restarted in observational data.
Thank you. And since you mentioned Ed Fu, if I could ask a broader question about that, is, like 20 years ago, we would say, hey, just do logistic regression and that takes care of it. And then propensity score matching came along and that is like the hot thing that we have been doing. And now there is all this causal inference movement with Miguel Hernan and Ed Fu that you have been involved in. I think you were one of his supervisors. Do you think that's the, for people who are training in epidemiology and doing these studies now, is that should they still stick to propensity score matching and regression analysis, or is this? It seems very complicated. I didn't understand half of what he had done. or your group had done. But is this something that is worth investing in? And is that the new way forward to take care of the selection bias?
Yes. So in that paper, he's used this kind of simulated population, and it's a really nice approach to dealing with a very small source of bias. So it's a tremendous, it really captures this. It really deals well with this period of time when we don't know what drugs people were taking. And in a whole big study over a long period of time, that is actually a relatively small source of bias. And so it looks, I mean, I share some of your concerns, really. It is a hot thing. It looks great. It's hard to understand. But I don't think it deals with any of the fundamental problems. And in the same way that we can say that propensity score matching only really improves dealing with confounding a very small amount compared to standard multivariable adjustment, unless you've got huge data. I think that will turn out to be a complicated way of dealing with a small aspect of confounding. And I think that really understanding the data in a simple way is the key thing. And then you can build lots of analytical additions on top of that. But it's really understanding the simple sources of bias and confounding, which you've all picked up.
Thank you. That does seem to be the key. And I think we are just at time. So thank you again for that wonderful overview of some of the stuff you're doing. You're doing much more in this area and more. People who are on Twitter can follow Laurie at Roxytonin. And thanks again. Hopefully we will, meet in person one day sometime.
Well Great, it was really lovely, and I hope it was of some interest, and have a great day.
Thank you. A quick question, Laurie. I've recorded this and we put some of these talks on our YouTube channel. I forgot to ask you at the beginning. Is it okay if we do that? I think most of what you showed is published now.
Yeah, it's fine. So I'll have to email the Swedish people and apologize for not giving their reference.
That's okay. We can add that. Thank you. Thanks again.